Okay, Chapter 10 is about the service provision of oral rehabilitation services to the adult population. So, in the clinic, we are beginning to see more individuals with hearing loss earlier in life, into their 40s and 50s, and we're also seeing young adults coming in, um, meaning teenagers into their 20s with hearing loss. And they think it's because of the amount of music that they listen to, the kind of easy access of music with AirPods. For many of us who are in our 40s, when we were kids, that's when the ability to take music with you, if you will, became more prevalent. And we had things like the Walkman and the Discman, which were larger devices that we could put CDs in, we could put tape players in, or put tapes in, but they were all hardwired, and so they had headphones, and so most people didn't want to deal with that. Now everything's wireless, so everybody's using. I mean, you see students all the time walking around campus. You guys might even be some of them, with AirPods in all the time, and so it's very important that those, because you're being exposed to more sound, that you keep the volume a bit lower. But here are some other factors that they think are causing hearing loss earlier. So in healthcare, there's a big push for what they call patient-centered healthcare, and hospitals in particular, their reimbursement is determined by patient satisfaction surveys. Now, I have to say that I feel like that's dangerous, because you as a professional can provide the best care, and the outcome may not be what the patient wants it to be, and therefore they're unsatisfied, but you have done everything in an evidence-based way. So patient satisfaction surveys can be dangerous and misleading. However, Medicare insurance companies are requiring that people measure patient satisfaction and try to provide what they call the patient-centered care. Okay, so it's, considering the patient's background, their current status, what they need, what they want, and kind of putting that all together. But that's called a patient-centered approach, and we take that when we provide oral rehab services. So over time, when hearing decreases, primarily you see a loss in the high frequency region, and we know that most of the intelligibility in speech is in the high frequencies, and the power in speech is in the lower frequencies. In adults, when they experience this high frequency hearing loss, start to report a few things. One of them, that speech is mumbled, speech is audible but unclear, and women and children are really hard to hear compared to men. Those are the three most common complaints for people with high frequency hearing loss. And then background noise is very difficult. So when we're looking at developing AR programs, there's a whole bunch of factors, and I want you to review them in the text. But here you can see a visual that shows them. Age, gender, socioeconomic status, which will affect what hearing aids they can likely purchase, what stage of life are they in. That can be misleading too. Along with age, you might think that somebody's not as active in retirement, but in many cases, they're more active than they were when they were working. So review these in the text. So when we, anecdotally in the clinic, we see that approximately, I would say, 8 to 9 out of 10 people, here it says 70 to 80%, people who have hearing loss experience tinnitus. And we don't know why. We kind of have an idea of how tinnitus works, but it's still a great unknown. There are certain types of sounds that people report which are listed: leaves rustling, ocean, a roaring kind of sound, crickets, high frequency, high pitched sound. One important piece is that if anybody ever reports a pulsing tinnitus that coincides to their heartbeat, that's usually an indicator of a significant medical condition that needs to be referred to a physician. But again, the tinnitus varies. We don't know a lot about it. It can be caused by a specific injury or some kind of external factor, or it just could be kind of idiopathic and you have no idea what's causing it. So we have to look at where the patient is in their journey. We know it takes about 7 years from the time somebody first notices a hearing loss to get hearing aids. Usually takes them about 4 to 5 years to come in for a test. So before they will come in, they're kind of in that pre-awareness. I think I have a hearing loss stage, and then they're tested, and then they're aware. But then the movement to get them to pursue something is difficult. Specific diagnosis, once that occurs, then then things can begin. So here's the 6 general categories for the plan, which you can review this in the book, in the text. There's the assessment, the informational counseling, the development of a plan, implementation of the plan, assessing of the outcome, and then the follow-up. And we'll go through each one a little bit. So when we talk about the assessment, these are the tests that we do. Not every clinic does all of these tests, but at a minimum, there's some that are done, such as the case history. Everybody should be doing that. The audiometry, which is determining the type and the magnitude of the hearing loss. Measuring loudness discomfort levels. So if you remember, we talked about in the hearing aid section, there's 2 types of speech levels that we test. We test most comfortable levels, and then we test MCLs and then LDLs, loudness discomfort levels, in addition to all the other speech audiometry. Everybody does an otoscopic inspection and does cerumen management if needed. Any need to send them to the physician. And then counseling, that's an important component. Assessment for the candidacy of hearing aids, and then if there's any medical clearance needed for any kind of medical condition. So other things that we include in the diagnostics are, hearing aid related difficulties. So these are the questionnaires that we use, whether they're structured or unstructured, to really get a good feel of where the patient's at. And then we look at the individual factors such as patient's age, psychological well-being, life factors, and again, all of that goes into the hearing aid process. So when we counsel them, we talk about expectations and kind of assess their motivation. We discuss the hearing and the speech audiometry test. We confirm their hearing loss. We considered different types of listening devices, whether it's a hearing aid, a cochlear implant, and we give them information at the time. And then, of course, we're there to affirm the patient's frustrations. And it's really important to, when you're counseling patients, I think this helps build rapport with patients. It builds a sense of trust that you're listening to them. But when you're counseling, it's important to look at the situation. You're going over the hearing test and you say, "Oh, Mr. Smith, I noticed here in the history, you said that you had difficulty hearing in background noise and that people sound like they're mumbling." Well, and then go on to explain about the speech signal, high frequency loss, what we always see. And then it makes it more personal, like you were actually listening to them, and you're taking their issues, their frustrations into account. So the development of the plan, you need to have objective and goals that are worked out with the patient, and then these goals should define the effective intervention and will be set in direct response to their particular problems. Again, that's why the case history is so important. And then we need to identify how we're going to evaluate those outcomes. Remember, goals must be specific. Patient, frequent communication partner, and practitioner must be committed. So when we're setting goals, we need to define the roles and responsibilities of each person involved. Talk about the conditions to accomplish these objectives. So essentially what that person needs to do. Do they need to do some work at home? Do they need to spend X number of hours working on this? How we're going to evaluate it, and then the time frame that we're looking at to reach the goals and objectives. Now, this slide in the book, it talks about joint decision making, and I always kind of approach this with a caveat. At the end of the day, the patient is the ultimate decision maker. The frequent communication partner technically doesn't have any decision making power, but it's you try to facilitate this joint decision making. But at the end of the day, what the patient wants, the patient gets, and it's not up to somebody else. So oftentimes we'll have, senior adult parents testing in the booth, and they don't want their children to come back who are like in their 40s and 50s like me, right? So in no way, shape, or form do you have to allow their family to come back even if they want to. It is up to the patient. So I usually say, Mr. Smith, we're all done. Would you like your family to come back, or do you just want to talk about it with me, just you and I? And that gives them the choice, okay? Because a lot of times family members want to come back and interject and for good reasons. I understand that. But at the end of the day, it's the patient's decision. So we're going to implement things: hearing aids, cochlear implants, assistive devices, tinnitus management. We're going to talk a little bit about tinnitus management when we talk about assessment, and I will make sure we talk about that again. Telephone training, so getting them to use the telephone. Auditory brain training, so there are these kind of auditory trainings that they can do. Communication strategies training, which we talked about, and then potentially speech reading training. So I want you again to review Chapter 3 because there's a lot of good information about hearing aids there. So it talks about candidacy, so deciding. I'm going to post some videos about deciding about hearing aids. Electroacoustic properties are verified. So this is all the stuff that audiologists do. We do real ear measures. We discuss how they work. We teach them how to insert and remove, practice with the telephone. All the different things related to hearing aids are in Chapter 3. So the tinnitus assessment, basically what we're trying to do is figure out what does the tinnitus sound like, what pitch is it at, and then how loud is it? And then based on that, we can do some masking with hearing aids. Many of the hearing aids available today have these masking abilities, so you're able to put noise in their ear, and it kind of helps reduce the effect. We use questionnaires. There's a whole bunch of different treatments, all of which I don't need you to know. But tinnitus with just using hearing aids usually helps reduce the effect. And then the frequent communication partner, they often have to compensate for the individual. Sometimes there's resentment, sometimes there's issues, and that's what we're there to do and to help. And then again, we have to understand the patient. We have to understand their wants, their needs, their environments, everything about them. So oral rehab planning is very, very individualized. So that's it for Chapter 13 or Chapter 10.